Hi and welcome. I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. I recently met an innovative young woman. Her name is Hannah Herbst while attending the annual Eagles EMS Conference in Fort Lauderdale. Hannah Herbst is a graduate of Florida Atlantic University, selected to Forbes 30 Under 30, and founder of a company called Golden Hour Medical. She has a background in IT and developed an automated pneumatic tourniquet known as AutoTQ, which we're going to discuss at length here. Also joining us is Dr. Peter Antevy, a pediatric emergency physician, medical director for Davie Fire Rescue, as well as Coral Springs Parkland Fire Rescue as well. Peter is a member of Eagles Alliance and also highly involved in high-quality research in prehospital emergency care and quite well known in Florida and nationally. Welcome to both of you.
Thank you very much. Very grateful to be here.
Yeah, thanks so much for joining. So Hannah, I'll let you really start by explaining what AutoTQ is and then compare that to a standard combat CAT type tourniquet.
Yes, thank you. So blood loss is unfortunately a leading cause of preventable death and trauma. And when there's blood loss occurring from an arm or a leg, the easiest way to stop it is by applying a tourniquet, which is this compression type of device that you place above the site of bleeding, and it applies a high amount of pressure to stop blood flow through the limb. Currently, tourniquets on the market have failure rates as high as 84%. And this became very real to me back in 2018 when I became aware of mass casualty incidents when I was a student. And so I became interested in how we can reimagine the conventional tourniquet and try to make it something that's very user-friendly, much like an AED. And so my team and I developed AutoTQ, which is an automated tourniquet. You press one button to wake it up and one button to inflate it. It guides you through the process of placing it above the site of bleeding on a limb, which is a leading cause of tourniquet failure, and being able to effectively administer treatment to a patient that may bleed out.
So in terms of tourniquet failure, how often do standard tourniquets fail, like the CAT combat type tourniquet?
Unfortunately, they fail very frequently. So there are several studies that have been conducted to evaluate this. Many of them occur immediately after training, and they found failure rates between 80 and 90% for the current conventional CAT tourniquet immediately after training, which is very concerning.
Mm-hmm. In terms of failure, was it the windlass aspect of the tourniquet that failed, or was it something related to the actual strap, or was that sort of in any way detailed?
There's usually a few different failure points that have been found in the literature. So one is placement. A lot of times when you're panicked, you don't remember exactly how to place it. It should be placed high and tight above the bleed and not over a joint. And the second problem is inadequate tightness. So for a CAT tourniquet to be effective, you have to get it extremely tight on that first pull before the windlass is activated. And a lot of times people don't remember that in the stress of the moment.
Right. So Peter, let me bring you into this. So in terms of tourniquet application by your medics in the field, certainly the CAT type device has been in existence for quite a while. Hannah's proposing a new iteration of how to do this, which is certainly automated, simple. What is your take on such a device, and maybe explain a little bit how you learned about Hannah's device itself?
Yeah, absolutely. We've been training on tourniquets ever since the military data showed that there was an extreme benefit in using them. We've been doing training for many years, including our police officers, and what we've noticed is that every time we gather everyone together to show them how to place the tourniquet, and we have to do one-on-one sessions with them, it's not a device that they can easily put on. And these are police officers who had the training last year. And like Hannah said, most of the time they have a problem kind of unraveling it, understanding how to actually place it. It's easier on the arm than it is on, for example, on the leg. You can imagine it'd be harder to place it on your own leg, especially if you had an injury. And then they don't tighten it well enough, as Hannah just mentioned. And in order for a tourniquet to really be placed properly, it's going to hurt that person. So a lot of people have that tendency not to want to tighten it as much as they can. Having said that, how I kind of got into all of this is because I'm the medical director for Coral Springs and Parkland, and unfortunately had the 2018 Valentine's Day murders that happened there, and we unfortunately lost 17 adults and kids. 17 people were saved that day, however, and the credit goes to our police officers who actually had tourniquets on, chest seals on, before those patients were brought out to EMS. So a lot of lives were saved by the tourniquet. If you look at the Boston massacre and you look at many other events that happened, I believe, and I've always believed this, that tourniquet should be in the glove box of every citizen. It should be in every schoolroom. Um, they should be in buildings along with the AED. And in my town of Davie, we were the first in the country to add an ordinance that required a stop the bleed kit in the AED cabinet, and those were required by buildings of certain sizes. So in order to get this life-saving device everywhere, I think it has to be put into local ordinance and supported by states and supported by the national folks, which they are doing.
So in terms of adoption of such a device, certainly it has to go through rigorous testing, maybe some trials. Hannah, where are you at in terms of, really vetting this in terms of any type of trial, or has it been compared head to head, with standard tourniquets?
Absolutely, yes. So we're currently doing lots of field testing. So we're doing testing on emergency vehicles in the surgical setting with lots of different customers. In addition, we're running pilot studies at different universities and with different organizations, including the military, to make sure that this device is effective. We're evaluating cognitive offloading of people. We're hoping to start that study later this year. So we're excited to be doing this in a variety of settings. We're also testing, obviously, the quality of it in different environmental conditions, under different pressures, atmospheric pressure. So we're doing everything we can to ensure the device is safe and effective. And we're excited to scale and fill our pre-orders and be able to develop this and deliver it to many people.
That's wonderful. I was wondering if you could describe the actual device. There's a brain part of it you were explaining to me when we met initially. And then obviously the strap aspect of it, I was curious about contamination and reusability issues.
Absolutely. That's a great question. And one of the limitations of conventional tourniquets on the market is that it's a single use, and often it requires two tourniquets to stop a bleed, both of which have to be disposed of. With AutoTQ, we have a reusable component and a disposable component. And I actually have one here that I can show you. So we have a cover on it that says stop the bleed, slide up and power on. So you just pull this cover off, and then you have a few simple commands. So you have power the device on. So I'll just click this button.
Tighten strap above bleeding, then press inflate.
It delivers audible instructions telling you exactly how to use the device. Then you tighten it above your bleed on the limb and you press the inflate button. Then it administers air into the cuff and stops the patient's bleed.
Well, that's amazing. In terms of ischemia time, how can a device like this certainly make it easier for us to know when to sort of let the tourniquet down and allow some blood flow? Because certainly limb salvage is important, and we don't want to have necrosis and so forth.
That's a great question. The limb salvage rate when tourniquets have been used is 85%. So when used correctly, you could really improve the outcomes for many patients. On the flip side of that, there's something called tourniquet conversion. It's exactly what you mentioned. It's making sure that the tourniquet doesn't stay on for too long of a time. And if you can imagine a patient going to an outlying hospital where there's no trauma center, and then that patient then has to be moved a couple hours to the trauma center, could you potentially have a tourniquet on for too long that then ends up causing the patient a bad outcome? And the answer is yes. So I actually just had someone on my webinar recently describing the appropriate conversion techniques of tourniquets. You don't find too much of that in the literature, but you really have to ensure that as you're taking the tourniquet down, that the bleeding is actually stopped. It's not really recommended to take a tourniquet down if the patient was just acutely bleeding. However, imagine a situation where a tourniquet was put on incorrectly. Let's say a patient got nervous and they just put it on a patient who didn't really need it. You really have to understand how to evaluate that wound to be sure that as you're taking the tourniquet down slowly, that the patient doesn't re-bleed again. But I think there's two sides of the question, Rob. One is making sure it's not on inappropriately, and then the second one is making sure it's not on for too long, which ends up causing ischemia to that limb.
So Hannah, does your device collect data on a number of hours or minutes that the tourniquet is put up, and then automatically deflate it in some sense to allow for that improvement in limb salvage?
That's a great question, and I really appreciate your answer as well, Dr. Antevy. Ischemia time is a very important and critical component of tourniquet use, and this is something when we were designing AutoTQ that we took into high consideration. So what we found when we evaluated AutoTQ versus a CAT tourniquet in a mannequin model is that AutoTQ can achieve cessation of hemorrhage at around 400 millimeters of mercury, while CAT requires 700 to 800. So already our ischemia time is slightly extended just based on existing literature with pneumatic tourniquets because it can stop the bleed at a lower pressure, which causes less complications with the patient's limb. There are different features that we build out for different customers. So depending on what people want, it is possible to deflate the tourniquet. However, typically, you're within the hospital within 30 minutes. And so it's quick to get them there. And then the physician can treat and take that tourniquet down in a supervised and controlled setting.
Absolutely. And in terms of obese patients, you have adjustable straps that will accommodate for that aspect.
Yes. So we have different cuff sizes to accommodate different limbs. Yes.
That's great to hear. So Peter, in terms of usability, in terms of pre-hospital, where do you think this is going in the next, 3 to 5 years?
I'll start with the public safety sector of the United States is the one that is actually first on scene. So whether you're talking about police officers, you're talking about EMS, it would behoove us to have tourniquets everywhere. And on all of my ambulances, across all of my agencies that I manage, we have quite a number of tourniquets on those ambulances. Obviously, cost is a factor, and I know that Hannah has done a great job of making that brain reusable so that all we have to do is purchase the straps, which are effectively the same cost, I understand, as a typical tourniquet you would purchase. Moving forward, though, however, I think that this has wide scalability to the public market. So whether it be schools, office buildings, the glove box, etc., where you don't want to have to teach somebody. It's really impossible to teach somebody how to do this the right way. If you have to teach them how to put the strap on, tighten it correctly, etc. So if there was an easy way, like Hannah has developed, of just putting it on and pushing a button, then I think that the outcomes and the scalability are much further beyond what we can do in EMS. And so I think there's great value in both markets.
And this is the AED of bleeding. You have a device here that has wide scale interest, certainly from the public and private sector. So Hannah, in terms of battery decay, how would that work out if it was in someone's garage? Let's just say someone purchased it and they hadn't used it in 3 or 4 months. What type of decay are we looking at, and can they rely on it?
Yes, so AutoTQ is rechargeable by a USB-C port, and our battery lasts for a year. So once a year, you'll get an email reminder that says, hey, please charge your AutoTQ and make sure it's up to the battery level. But we do everything in our power to make sure that our consumers are checking their batteries and that they're ready to go.
Okay, is it heat and fire resistant? In terms of durability, does your device have?
Yes, so just like any other medical device, we come with manufacturer recommendations for the upper and lower bounds of temperature, different storage recommendations. So all of that is in our instructions for use.
Mm-hmm. I see. And Peter, getting back to, I guess, logistics in terms of adoption, do you feel that in the long term that, number one, this device will be something that we're going to be seeing, widely adopted just going forward?
I do, and I'll tell you why. When you look at AED use in this country, the odds of someone actually getting an AED and using it correctly are still very low in this country. And part of that is because it's complicated for a lot of people to do. And I think that, so getting tourniquets everywhere is step number one. And I think the federal government and the Stop the Bleed program that has started is really making that happen. We talked about ordinances, but then ease of use, I think, is really the key. You have people who oftentimes have their child in cardiac arrest in front of them. They won't put 2 hands on the chest because they just are afraid of doing it. When you have a device that's a tourniquet, that's right, a single button turn on and single button inflate, I think that would make it much more likely that that person will use that device when they're passing the scene of an accident, as an example. We've had many, non-MCI events that have had tourniquets. We've had some media stories on them where they're just happening because someone got into a motor vehicle accident. It doesn't have to be a school shooting. So I think the tourniquet should be everywhere and should be easily used by everybody.
Okay. Regarding sedation, is there a need because of the pain involved with the application? How would you sedate a patient, pediatric or adult, who needs, a tourniquet?
We always evaluate people's pain. If the patient's in extremis, we're just going to be managing and trying to get them back to life. Once somebody is Correct. Stabilized and is exhibiting pain of any sort, even, for example, after we intubate somebody, we have to sedate them, provide them pain control because they have a piece of plastic in their trachea. It's the same thing here for a tourniquet. These are painful, and we do have the appropriate medications on our vehicles to address that pain. And again, just simply the trauma itself is very painful. So we do address that in EMS, and I would say most public agencies across this country would address pain appropriately.
So, Hannah, can you talk a little bit about public training types of approaches? How would you train a consumer who purchases this type of device?
So a huge part of our mission is making blood loss prevention and control training accessible to a wide variety of people. And one way that we're able to do that is through our online training platform. So when you purchase an AutoTQ kit, you plug it into your computer and it walks you through the process of using it. It lets you practice on your own limb and on your buddy's limb just to be able to effectively apply it. We think this will have huge impacts in making sure that people are prepared and ready to stop the bleed with AutoTQ.
Do you recommend people training once a month in general just to keep their skills up to use this? Because, in the throes of a trauma and, very chaotic situation, people sometimes lose their ability to kind of think clearly and straightly.
Yes, so one of the studies we're actually conducting is a learning curve study to try to figure out how quickly these skills degrade over time. We know that with the windlass tourniquet, it degrades within moments of training. With AutoTQ, we think the learning curve will last much longer, and so that's something we're evaluating. But of course, we recommend people train as often as they can.
Now, Rob, if I can mention that there's a concept of just-in-time training, and I think that with having the expectation that people are going to be training frequently, unfortunately, as many of us know, even with the AED as a perfect example, that people don't do that. So yes, I would agree that you have to train at least once a year is what I would say. And for example, at my office, we have a 2-hour training that goes over all these different items once a year. But then the device itself should have the ability to allow you to figure out how to use it just in time, whether either be a video or like Hannah's device by audio. So I think that having both those things would make it more likely that the device be used when needed. People panic, and if they have a device that can talk to them and walk them through it, much more likely to use it at that time.
Any other final thoughts? I'll let you both maybe have a few pearls to take away, and Hannah, I'll start with you.
Yes, I'm very grateful for your time, and I'm very excited about the potential for AutoTQ. To me, it's so exciting to see people pre-ordering the device now. We've had people from school bus companies, we've had small sports teams, and I think just like Dr. Antevy said, tourniquets aren't limited to mass casualty situations. Blood loss can happen anywhere and to anyone, and being able to equip people and serve them to better prepare them for this happening to themselves or their friends or their family is just the honor of a lifetime. So thank you very much for covering the device and for having me today.
Oh, of course, my pleasure. And Peter?
I think that the citizens of this country, everyone who lives across the world, has started to understand that there are things that we expect from our people, from the community. And, we expect them to do CPR, cardiac arrest. We expect them to know how to use an EpiPen. We expect them to know how to use an AED. And we also expect them to know how to stop bleeding with a tourniquet. And so I think that the American public has gotten to understand that these devices are very important, and having a device that's easily used, that I could teach you in 10 seconds, that speaks to you. These are all things that make this product, I think, have great potential. I do look forward to the studies, not just the cadaver studies, but the real human studies. I know Hannah's really a phenom and has been doing all of these things so that this product can be on the shelves of Walmart and CVS one day. So I commend you, Hannah, for everything you're doing, and wishing you the best of luck, and we're here for you.
And same here. Really, congratulations on your innovative capability and what you've done in order to change the outcomes of bleeding related to penetrating trauma. Thank you so much. Appreciate both of you for joining. It's been a great discussion. Thanks again.